Today's topic is diabetic retinopathy, which I hope to cover in 10 minutes. So in order to get into a discussion of retinopathy in diabetics, we first have to understand microangiopathy. And just like the word sounds, it is pathology or disease of the small blood vessels. So if we're going to take a look at a capillary in the body, this would be the endothelial cells lining the capillary, and we can give that capillary some nuclei. The blood cells flowing through the capillary, as well as proteins of various sizes. And we also, especially in the diabetic patient, would have lots of glucose and glucose derivatives. In a diabetic patient, because of the chronic hyperglycemia, these glucose and glucose derivatives actually end up binding to the proteins and forming what are called advanced glycated end products. So these advanced glycated end products in the capillaries will actually be the cause of a lot of what we see in diabetic pathologies. When we have T cells or macrophages come along, they have what's called the receptor for advanced glycated end products, which, as you might notice, the abbreviation is RAGE. Gives you a sense that it's a good way to remember that these are not very good receptors for you. They're not happy receptors. So the glycated end products, the advanced glycated end products, end up binding to their receptors. They're receptors for advanced glycated end products, which causes a release from T cells and macrophages of various factors. And these factors are pro-inflammatory, so they're going to attract other T cells, macrophages, and immune cells. So it's going to magnify the initial effect because you'll have more cells releasing more of the same factor. So you have a multiplication of the original signal. But in addition, the T cells and macrophages are going to cause the release of oxygen-free radicals, which are not good for most cells in general. They'll damage the endothelium, which puts endothelium in a prothrombotic state. So endothelium will be kind of ready to form clots because it's damaged. So we have a higher likelihood of clots floating around, prothrombotic. In addition, we have collagen in the extracellular matrix out here, which the advanced glycated end products, the AGEs, can directly bind. When they bind to these collagen fibers, they're going to start forming crosslinks. So we have crosslinks formed, and this makes the extracellular matrix far more brittle. When it's brittle, it's hard, inflexible, and brittle, and this prevents the endothelial cells from properly binding to the extracellular matrix as it's moving around. And when that happens, you end up with spaces between the endothelial cells, and plasma is going to leak out, leading to edema in these areas. Before we go into diabetic retinopathy, we have to do a quick overview of the anatomy of the eye. So if this front layer right here would be the cornea, then this would be the lens. This would be the ciliary body, which also has something called the canal of Schlemm in there. And funny name for something, but it's basically the place where aqueous solution, which fills up the front, kind of the anterior portion of the eye, flows out into this canal of Schlemm. So it's an exit pathway for aqueous solution, aqueous fluid in the front, in the anterior portion of the eye. And if these get blocked, then we have a buildup of pressure in the anterior portion of the eye, which is one of the causes of glaucoma. In the back of the eye, we have something called the vitreous body, which is a gel-like solution that maintains the shape and supports the body of the eye. At the very back, there's the retina, which we see right here, which is this layer of nerves and ganglia that receives the information of the light from outside the eye. The light passes through the lens, focuses on the retina, and the signal passes to the brain through the optic nerve. So basically we're going to put together everything we've been doing so far, and what we end up with is this is the retina and this is the vitreous body. If we were to draw it out just to give you an idea of where we are, this would be the lens, the front of the eye, and the back with the optic nerve. This is what we're drawing here. The retina along with the vitreous body here. Together, if we were going to take a quick picture, pull it up, we would get this. So as I said, this outer layer would be the vitreous body, and this whole part in several layers would be the retina. As we mentioned earlier, the effects of microangiopathy leads to, among other things, damage to the blood vessels, which will cause microhemorrhages as well as microaneurysms. So just to be clear, so everybody knows, the difference to a microhemorrhage is actually leaking out blood into the extracellular matrix, while a microaneurysm would be an expanding or ballooning of the blood vessel because of the blood vessel wall weakening. So this would be like an aneurysm, and this would be just a popping of an aneurysm would lead to a microhemorrhage, for instance. In addition, we have general decreased perfusion of the various layers, and because these layers are basically hypoxic or struggling for oxygen, they're going to start releasing factors. We're going to draw this in purple here. And this factor is called vascular endothelial growth factor, or VEGF, vascular endothelial growth factor. And this factor is actually responsible for the creation of new blood vessels, neovascularization, in response to the lack of perfusion by the current blood vessels. Problem is, these blood vessels can occlude areas that and damage the general structure of the retina, so it's not good. This stage in diabetic retinopathy is called background or pre-proliferative diabetic retinopathy, and basically it's defined by the hemorrhages, aneurysms, and vascularization, neovascularization within the retina itself. The next stage is when you actually have neovascularization on top of the inner limiting. This is called the inner limiting membrane of the retina. So the membrane that separates the retina from the vitreous body. If you have blood vessels growing on top of this area, that means you have a lot of VEGF being released, and what that can lead to is traction, first wrinkling of the retina, and then traction of the retina that causes a pulling away of the retina from the bottom layer, which is, we have depicted here, which is called the retinal pigmented epithelium. So when you have the rest of the retina pulling away from the retinal pigmented epithelium here, what we end up with is called retinal detachment, and clearly that's not good. So that's a situation you definitely want to avoid, but that's all the time I've got, so I hope you've picked up a few things about diabetic retinopathy. Thank you.